Hi everyone, I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Docs Podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopedic Society for Sports Medicine annual meeting in Nashville, Tennessee.
The AOSSM annual meeting is the premier sports medicine conference each year, hosting over 3,500 attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lecturers. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 7 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the AOSSM annual meeting. This episode is brought to you by Arthrex, a global leader in minimally invasive surgical technology and the innovators behind the only device cleared for treating pediatric ACL injuries.
Specifically designed for skeletal immature patients, the Arthrex tightrope implant is the first and only device for ACL injuries cleared by the FDA for pediatric patients, with techniques that avoid the growth plates during ACL repair or reconstruction. Pediatric-specific instrumentation guides allow you to drill sockets for the new, reconstructed ACL, again, avoiding the growth plate, and diminishing the potential for growth disturbance.
Learn how the Arthrex ACL tightrope surgical implants can benefit your patients, from youth to adult, at arthrex.com. Be sure to follow at ArthrexMedEd on Instagram and Arthrex on LinkedIn for the latest in product innovations, medical education opportunities, and more. Arthrex keeps changing the game in sports medicine innovation and helping surgeons treat their patients better. Hey everyone, before we dive in, we've got to give a quick shout out to AOSSM and their Sports Docs program. Such a great partnership and honestly something we've been really excited about since we began working together 3 years ago. Also, if you're in sports medicine, and if you're listening to this, you probably are, you've got to check out their virtual team physician series at sportsmed.org. It's packed with everything you need to keep athletes of all ages performing at their best, on the field or off. I've checked it out myself, and it's really a game changer. All right, let's get to today's guest. Today's episode is going to focus on ligament reconstruction in skeletally immature patients, including various growth plate sparing ACL reconstruction techniques, MPFL reconstruction considerations, and clinical outcomes. We are joined today by 2 outstanding guests.
Dr. Mininder Kocher is a professor of orthopedic surgery at Harvard Medical School, chief of sports medicine, and director of sports medicine fellowship at Boston Children's Hospital. He is the former president of PRISM and POSNA and serves on the board of directors for AAOS and AOSSM.
Dr. Lauren Redler is an assistant professor of orthopedic surgery at Columbia University Irving Medical Center and is actively involved in medical student, resident, and fellow education at Columbia Ortho. She has published extensively on surgical treatment of ACL tears and patellar instability in pediatric patients and actually presented her research on the outcomes of MPFL reconstruction in skeletally immature patients at AOSSM this year. So without further ado, let's get to the exhibit hall. So Min and Lauren, thank you so much for taking time out of your busy schedule to be here with us live at the AOSSM annual meeting in Nashville. Welcome to the show.
Thanks for having us.
Yeah, thank you very much.
Mm-hmm. Yeah, thank you. All right, so today we're going to be talking about Physeal-sparing knee surgery, specifically ACL reconstruction and MPFL reconstruction. And so before we dive into that, we just want to talk a little bit more about assessment of skeletal maturity. So as far as, I know Ashley and I have been at Boston Children's as residents. Mm-hmm. We do know a little bit of the workup. We have a preview, but if you can share with the listeners. Lauren, let's start with you. How do you do your workup for skeletal maturity?
Yeah, absolutely. So I have my mentor here who I learned it from Min, but a left-hand bone age x-ray is standard of care. There's tons of different ways that you can assess age. There's massive atlas of Gorlick and Pyle if you want to go through all of the different key features, but there's some really great shorthand bone age assessments, one published by HSS and Ben Hayworth from Children's, actually, when he was a resident there, and then we published one recently from Columbia, and it's a Sick Kids combination with Columbia, shorthand, looking for one salient feature for each age. And so for the key age of kind of thinking about going across a growth plate for a boy of 14, looking at that distal radius as the epiphysis is capping, and for a female of 13 that their thumb distal phalanx physis is closed. And kind of those are the two things that my eye goes to right away on a hand x-ray to say, can I go across that growth plate?
Yeah, super helpful.
That's really helpful. So now we want to shift to discussion
Could
of
I just add?
Oh,
to
yeah,
that?
please do.
Because,
Yes.
I think we use the left-hand X-ray Grulich and Pyle as well, and I think it's very helpful to get their skeletal age. I think there are other ways of thinking about growth as well, and so we think about their physiological stage. So have they hit puberty or not? You know, there's the Tanner and Whitehouse staging system, which obviously, as orthopedic surgeons, we're not going to, do.
Sure.
There are some surveys where patients can do their self-staging on Tanner that can be useful. Asking a female patient if she started to have periods yet, onset of menses, can be helpful because typically there's growth for 2 years after the onset of menses. And then we found actually the knee X-ray can be helpful as well because you may not have a hand X-ray when you see the patient for a knee injury, but you almost always have a knee X-ray. So the tibial tubercle apophysis can be quite useful. If it's not there yet as a bony apophysis, or if it's a bony apophysis that is not attached, fused with the epiphysis, then they are prepubescent. Once that apophysis fuses with the proximal tibial epiphysis, then they tend to be an adolescent patient.
Yeah, that's super helpful.
Very helpful. Yeah. So speaking a little bit now, focusing on ACL reconstruction. Now, before we get into the techniques, we want to know why is it important that we just discussed all of that? Why do we need to know skeletal maturity? So what are some growth-related complications you worry about when considering a young patient for an ACL reconstruction?
Yeah, I think the issue of a growth disturbance is very real, and I think it's scary to surgeons if they don't see a lot of patients with open growth plates. It's certainly scary to the families to think they could have a surgery and then have a growth disturbance where the leg grows shorter or grows off at an angle. And if that's severe, that requires, major operations, limb lengthening, angular correction as well. So I think the relevance is really if the patient has open growth plates and you're doing an ACL surgery, that distal femoral growth plate, the proximal tibial growth plate, and the tibial tubercle apophysis they're all right there. They're all in the playing field.
Mm-hmm.
Yeah, a lot to think about.
Yeah.
And, for our listeners, when we talk about ACL reconstruction in this age group, there's three broad categories, whether we're as far as the growth plate. So as far as Physeal-sparing or partial transphyseal or complete. Lauren, can you talk us through, in those three categories, how do you work through those? What are your different indications? And how do you decide what your preferred technique is going to be?
Yeah, absolutely. So with the skeletal age cutoff that I was mentioning before of boys of 14 and girls of 13, that's when I would feel comfortable going across the growth plate with a soft tissue graft, of course, and not having any bone going across that growth plate. Because I drill outside in with a flip cutter, that is going to be a little bit more of an oblique socket on the femur, so a little bit more of an injury to the growth plate rather than transtibial drilling with more vertical tunnel. And so giving those kids a little bit more time to grow before going across that growth plate. I think anything younger than that, I love doing the iliotibial band, modified Macintosh that I learned at Boston Children's from Min. I think that there's a sweet spot kind of in between those two, especially for savvy parents that are concerned about growth. And maybe it's okay to go across their growth plate, but if you can avoid it, especially on the femur, that's a nice tool to have in your tool belt to do a hybrid technique. And as long as their epiphysis is big enough to keep that graft all epiphyseal on the femur and going across the growth plate on the tibia, I think that's a nice kind of tweener technique to have.
Yeah, that's great. And you said, how did you describe the parents? They're more savvy?
Savvy,
So
yeah.
that's really interesting, and I think nowadays you do they say, I put my MRI into ChatGPT, and this is what it told me to do, or whatever. So are you finding that there is a lot of knowledge when you're coming into the office from the parents?
I mean, I think that, as a parent myself, and all of you guys can attest to this too, that your job is to protect them, right? And so they're advocates for their kid and doing the right thing. And I think it's nice to be able to help them along that journey and choose a graft and a technique together.
Yeah.
I think particularly for kids with open growth plates, because I think it's a little bit different situation than, a 17 or 18-year-old who tears their ACL, and there's lots of options around. I think if you're the parent of a child who's 10 and they tore their ACL, your options are more limited, and you're starting to do a lot more research. And we see a lot of families that will travel to have their surgery, or they see a surgeon who's not comfortable doing it and they get referred on to do the surgery. So it's a bit, particularly in the very young kids, it's a bit of a niche type of situation.
Yeah.
So we just talked about the different surgeries you would do for the different stages, and we want to talk a little bit about graft choice. So obviously if you're doing the modified Macintosh, like you said, that's IT band, but for the partial transphyseal or true transphyseal, what is your optimal graft choice? Does it change based on age or gender or anything like that?
Yeah, I think in the adolescent patient where you're open growth plates, you're going transphyseal or partial transphyseal, where you're going through the proximal tibial physis and staying within the epiphysis of the femur. We use a soft tissue graft, so we want to typically use hamstrings or quadriceps tendon. I think patellar tendon, is a problem because the bone blocks could be across the growth plate. We don't like to use allograft in young patients because the failure rate is so much higher than using their own tissue. So typically it's quad tendon versus hamstrings. I think there's pros and cons of both of those grafts, and there's surgeon experience with both of those grafts. I think in that population, that's actually an ideal population for an LET procedure as well, an extra-articular procedure, because they're younger, they're high risk, they often hyperextend. So we often add that to the quad or the hamstrings.
It's one of the reasons that I love the modified Macintosh so much, because it's automatically built in, right?
Yeah.
You get both.
Mm-hmm.
Yeah, so Lauren, what are your thoughts to build on what Min said as far as how do you approach the graft choice?
Yeah, so I agree, absolutely. Soft tissue, I'm definitely a quad fan. I think one of the dangers of quad in any age group is that you can overstuff the notch and the graft can be really big, and especially in these little kids that have tiny little notches, right? You're not cutting a 9 or a 10 millimeter graft, and so we all have this number in our head of something bigger than 7 or 8 used to hamstring data, and I think we probably don't yet know the number of what the quad needs to be, but we don't need to put a 10 millimeter soft tissue graft in, a 13-year-old kid's femoral epiphysis.
Yeah, I think that's a really important point, because I think even with hamstrings, we think, if you have a graft under 8 millimeters, the failure rate is higher and you need to supplement it, or you need to do a 5-stranded graft. But it really should be proportional to the size of the knee, right? So if you're doing a 13-year-old small female, that notch is not that big, and a 7 millimeter graft might be totally appropriate, and you put it in and you're like, yeah, that's plenty big for that patient.
Yeah, so how do you make that call? Because obviously you have to start on the back table, and doing your prep. Like, do you just sort of have a bit of an acumen over time and say, this is what makes sense to me? I can look at a notch and sort of have a number, or is there any sort of other things that you're doing?
Yeah, that's a good question. I think part of it is just sort of experience. So you know the size of the patient, you know the size of the notch from the MRI, you've harvested the graft, you know the size of the graft, and then you're in the knee and you're looking at the notch. You can measure the space between the lateral wall of the femur and the PCL and get a sense of how much space there is in there as well. But I do think that sometimes we harvest a hamstring at 7 millimeters in diameter quadrupled, and you're like, boy, that's a small graft. But then you look at the knee and you're like, boy, there isn't a lot of room for a graft in this knee. So.
Yeah.
I think, speaking to your point, though, about kind of having an idea beforehand and getting a gestalt maybe about the patient size, right? Because one of the first things the rep in the room asks is like, what quad pro do you want open? Like, what size should I get ready, right? Because they're all white box, like open just for that case. And so I think having an idea of what number you might want is helpful. You can always cut it down, right? You can't make the graft bigger. And so maybe erring a little bit on the bigger side, maybe a 9, and you can cut it down smaller if you need to, is nice.
Yeah. So, Min, you mentioned LET, and we definitely want to talk a little bit about that. So we know that our younger patients have a significantly increased risk of having an ACL re-tear, and so LET or ALL reconstruction, depending on what your preference is, has been described to lower that risk. So, young age being one, what are some other risk factors that a patient may have that would lead you to do an LET? Are you doing it in every young person, or are there certain other risk factors you're looking at?
Yeah, I think in that situation, adolescent with open growth plates and a soft tissue graft, hamstring or quad, I would say I'm almost always doing an LET, probably easily over 90% of those cases, and for a few reasons. I think one, it's clear that is our worst group for outcomes. The failure rate, ACL reconstruction in adolescents can be as high as 20%. So, that's the group that has the worst outcomes because they're going back to so much activity. And so that's one reason. If your failure rate is that high, what can you do to bring that down? I think beyond that, these are often patients who are loose jointed, so they often hyperextend. That might be an indication. They're often going back to high risk sports. They're going back to soccer, basketball, football, et cetera. And so, that would be another indication.
Mm-hmm.
Yeah, we always do the examiner anesthesia when you get into the operating room. The patient's nice and relaxed. Everyone gets a feel of what that knee with an ACL tear feels like. And in addition to the ligamentous laxity and the recurvatum, right? If it's what I call the med student pivot shift, right? Like they can feel it, they can see it. Like the rep can see the pivot shift from across the room. Like that patient needs an LAT.
Yeah, I agree. And Lauren, talk us through a little bit of your LAT technique, and then also I want to hear from both of you. When you do add the LAT, do you change anything about how you rehab them?
Yeah, that's a great question. So I love LATs too, and I find myself doing a lot more of them more recently. I think now that we're thinking more about it, that it's all at the forefront of our mind. And so something that changed in my practice is that, I consent all my patients for a possibility of it that I didn't used to do when I started. And then a pearl that I learned from Liz Dennis, which I love and I pass on to everyone who I can tell, is like you to harvest your graft and right away you harvest your IT band, whip stitch it, pass it under the LCL and clamp it. Then at the end of the case, it's 5 minutes to put an anchor in, right? Like a knotless anchor. And it doesn't add much time, but you're dramatically altering the patient's outcome. So I think preparing your graft right at the beginning of the case and making it so that you don't get to the end of the case and say like, oh shoot, like now I've got to do the LAT. Right?
Or there's a little soft tissue swelling.
Yeah, exactly. So like the tissue planes are all pristine. It's beautiful anatomy, right? The LCL is like so obvious. Their lateral capsule's intact. You haven't violated it with like scope fluid, pouring out everywhere. So doing it right at the beginning, I think is really helpful. And then there's lots of debate about what degree you should fix it in. I think especially if you're doing it with the BTB graft and you're worried about losing that extension, maybe fixing those into a little bit more extension. I'm more of like a 30 to 40 degree, fixation point. But you do worry that you could maybe prevent some of that full terminal extension.
Yeah, I think we're similar. I do tend to do it at the end of the case. It's about a 1.5 centimeter width of the iliotibial band. Bring it underneath the lateral collateral ligament, and then we fix it to a point that's sort of proximal and posterior to that lateral epicondyle. In patients with open growth plates, I'll often check that point with X-ray, and it tends to be just distal to the physis, so sort of within the epiphysis, and so that's useful. And then I usually fix it with a suture anchor or knotless anchor in that position. I also do it at 30 degrees. I was concerned about stiffness of the knee. We just actually completed a study where we looked at stiffness in age-matched patients and sex-matched patients with and without an LET, and we did not find an increased incidence of arthrofibrosis or stiffness with the LET.
Yeah, I think, in my own clinical data, I'm similarly not seeing any changes in arthrofibrosis. I would say just sort of anecdotally, I do feel like at that 2-week visit, maybe they're a little slower with their motion and maybe they're a little bit more tender. And they just seem a little bit more symptomatic with range of motion, but it all seems to be fine.
Yeah, I agree with that.
I
think at the 2 weeks they are a little bit slower, and then at 6 weeks they're right with everyone.
And I don't think it adds much, right? Like a lot of your young female patients might be a little bit worried about what is my scar going to look like. It's going to be a lot bigger. I tend to make, an incision laterally big enough for my finger so I can feel the button under the IT band on the femur. And unless I'm looking at growth plates, not needing to X-ray in every ACL. And honestly, the incision to harvest the IT band and put that other anchor in just above your button is not that much bigger. And so I think being able to reassure the patient that it's not that much more scarring is helpful.
Yeah.
And do you change your recovery at all, like in terms of
no change for me? Yeah. What about you, Min?
No.
Awesome.
Well, we also, have to talk a little bit about genu-valgum and how that is going to increase the strain in the ACL. And, we think about it as far as a risk factor, for the actual injury itself, but then also, in the rate of rupture after we've now put in a new ACL. So, Min, as far as your indications to add growth modulation procedure to correct this coronal alignment, like how does that all work into your workup?
Yeah.
Are you looking for expert orthopedic care close to home? Look no further than the Orthopedic Institute of New Jersey. With convenient locations across Morris and Sussex counties, OINJ brings world-class care to your neighborhood.
From sports medicine to spine, hand and wrist, joint replacement, and foot and ankle, OINJ has fellowship-trained specialists in every orthopedic subspecialty. They offer rheumatology and physiatry services, making them your one-stop destination for musculoskeletal health.
At OINJ, their nationally recognized physicians and surgeons combine cutting-edge innovation with compassionate care to help you recover stronger, faster, and better. Whether you're a weekend warrior, student athlete, or pro on the field, they specialize in getting athletes back in the game.
The Orthopedic Institute of New Jersey. High-level care. Innovative treatment. Right where you need it. Visit www.orthopedicnj.com to learn more.
Well, I think it's a really important factor to think about, and I'm glad you brought it up. But I don't think you think about it unless you see it. So I think you need to get the X-rays, the hip to ankle X-rays, before surgery on all these patients. So we did that as part of the Pluto study, and we learned some really interesting things. Actually, you are the lead author on a paper that's looking at pre-existing pre-existing alignment and leg length differences from the hip to ankle X-ray. But I think if you routinely get that in patients who are skeletally immature, it's very useful because then after the surgery, you can repeat. And if you do see an angular deformity or leg length difference, you want to know, was that there before? And if you didn't get the X-ray before, you wouldn't know. Right. But I think if you have a patient with an ACL tear, they have open growth plates and they have substantial genu valgum, like zone 2 for sure, maybe even far zone 1, I don't think it adds much to do guided growth. And so we typically do an 8-plate hemiepiphyseodesis on the medial side of the distal femur. I think you have to think about the other leg as well. If they're valgus on the other leg, we often do it on both legs because otherwise you'll make one leg straight and the other one will be valgus, and that's people don't like the way that looks. And so, but that is something we look really quite closely at.
One of the hardest parts of my conversation with these patients with genu valgum and growth modulation, right, for ACLs and also patellar instability, it's super powerful to help change that alignment, is the idea of maybe differential correction or differential rates, and that you may have to go in separately to remove the implant if one side is correcting faster than the other, and the idea that that might be an additional surgery. I haven't seen it happen a lot, but it's certainly something I bring up and talk to the patients about. And I think that can be something challenging as a patient to think about maybe needing an extra surgery if one of them is correcting a little faster than the other.
Yeah, I bet.
But it's another good reason to get the hand X-ray for bone age, so you know how much growth they have remaining. Because if they have open growth plates, but they have less than 6 months of growth remaining, you're just not going to get much correction from a guided growth procedure.
Yeah, good point.
Definitely. So now we'd like to move on to MPFL reconstruction. And Lauren, you're presenting your research on outcomes of skeletally immature patients undergoing isolated MPFL reconstruction from the Jupiter cohort. So can you tell us a little bit more about this study and what you found?
Yeah, absolutely. It was such an honor to be part of the Jupiter cohort, and my mentor, Beth Schubenstein from HSS, and enrolled patients over a number of years early in my practice. So this study is looking at the difference in outcomes of patients with at least 2 years of growth remaining compared to their skeletally mature or near maturing counterparts. And the way that we distinguished who was skeletally immature was based on surgeon op report, and did they make some kind of modification of the femoral attachment of the graft or document that the growth plates were open, because we have a lot of radiology data on these patients as well. And then looking at their outcomes and looking at their patient-reported outcomes, Kujala, KOOS, the BAMF patellar instability index, and the Marks activity scale. And it really interestingly, the skeletally immature patients at year 1 outperform the skeletally mature patients. They all return to sport at the similar, rates, and so there's not this decreased return to sport rate in these younger patients. But the data really shows that despite that kind of, leading outcome improvement, that those younger patients unfortunately have a 2-time increased rate of recurrence. And so taking it with a little bit of a grain of salt and saying, like, yes, I know you're doing so great now, but we still need to, make sure that you're getting your strength back and kind of going back cautiously, because we know that the data is there that their re-tear rate is still a lot higher, unfortunately. Both being female and skeletally immature was a risk ratio of 2 times higher recurrence.
Seems to be the common theme. Yeah, definitely.
As far as on this show, we speak about ACL injuries all the time, and we're always, that's always the thing. It's like, okay, and again, you're a female, and okay, and you have hyperextension, and always trying to figure out what are all the things that we can do to reduce that risk, and we'll tag on that a little bit at the end. But before we do that, so there's also a lot of different surgical techniques that have been described for MPFL reconstruction in the skeletally immature. So, Min, can you share, your tricks and your tips as far as like avoiding that physis, and like how do you go about it?
Yeah, it's a good question. So, I think because really patellofemoral instability is, I think, solidly an adolescent problem. So it is the peak incidence of patellofemoral instability is in adolescence. And so it's something we're going to see a lot of. And then for MPFL reconstruction, I think it's really, having been in practice now for 26 years, it's really changed patellofemoral procedures. Like we used to do, a lot of lateral release, medial plication, tibial tubercle osteotomies, even a Galeazzi procedure. And, we don't do as many of those anymore because of the MPFL reconstruction. So I think it can be a very powerful operation, but it's not, the end all, and it doesn't solve every problem. And every patient's really quite unique. But for MPFL technique, I think when you look at that point, Schottle's point, when you feel that little sulcus between the adductor tubercle and the medial epicondyle when you mark it, for me it almost ends up being right at the physis every time. And so I tend to err a little bit distal into the metaphysis, in the epiphysis, instead of putting it in the metaphysis, because I think as they grow, that may change the trajectory of the MPFL arm. I use an anchor, suture anchor, double-armed, and I use allograft for my graft typically. And I actually have two limbs. I have one limb going to the patella, the MPFL, and one limb going to the quad tendon. I'm reconstructing the MQTFL. And so that's sort of my preferred technique.
Yeah, Lauren.
I think in an adult patient, your kind of stepwise assessment of where your femoral insertion is, right? Anatomy matters most. Palpate that sulcus. Pass a graft or a suture, check isometry. So isometry matters kind of next most important. And then radiographically, that lateral x-ray confirming Schottle's point is kind of more confirmation, but maybe you're not going to change your point based on the x-ray alone because you already confirmed anatomy and isometry. So my order of attack for those is a little different in a skeletally immature patient, because on that lateral x-ray, right, because of that undulation of the distal femoral physis, it's going to look like maybe you're above it because it kind of, flares proximally. And so those are the only patients that I'll get an AP x-ray first, have my guide pin there, make sure that I'm parallel to the growth plate and aiming a little distal, versus in an adult patient, because I'm using an interference screw and a pulled through technique, aiming proximal and anterior, you can't do that going across the physis. So getting that AP x-ray first. And so instead of anatomy, isometry, x-ray, it's, anatomy, x-ray, and then isometry and confirming, but you don't have a lot of wiggle room because of where that physis is.
Yeah, absolutely. And then can we talk a little bit about rehab? What was done in the Jupiter study? Was it standardized at all, or was it not standardized? And then what do you do?
It is not standardized. We actually found that we were all pretty similar in our rehab protocols, but it wasn't a specific Jupiter rehab protocol. My standard, I think, mostly probably comes from Boston Children's, is that we keep them partial weight bearing for the first 2 weeks and then let them progress and do a 30, 60, 90 degree progression of range of motion every 2 weeks. And so I have all of my grid PT protocols that I stole from Boston Children's as I graduated fellowship 10 years ago that I still use. And
it's
so
just
that's,
like a
that's
rite
my
of
protocol.
passage.
Exactly. It is. Absolutely.
So we kind of briefly talked about for both ACL and MPFL, like we still think about, despite all these things, these advances in our technique and all the care that you're obviously giving to every little detail along the way, there's still a failure rate. So, as far as what else can you do, what are things, Min, that you're adding to your practice to try and help mitigate some of that risk?
Yeah, I think it's really prevention, and in this case, sort of secondary prevention. I mean, we have two McKaylee Centers for Sports Injury Prevention in the Boston area, and it's really changed our practice completely. So I think the ACL patients, the patellofemoral patients as well, once they're kind of towards the end of their rehab, we really try to get them working on an injury prevention program. And, the data are really clear. I mean, injury prevention programs for ACL can reduce the risk of re-tearing by 2 to 3-fold. I mean, it's a very powerful intervention. It's interesting that insurance doesn't pay, for trying to prevent an ACL, but they'll pay once you tear the ACL and you need surgery and rehab afterwards. But that's sort of a different story. But, anyway, I think getting them into injury prevention and having them think about injury prevention is really quite important. So, we're working on a lot there. We're working on their strength, matching their quad and hamstring strength. We're looking at their strength on the surgical side compared to the other side. We're looking at how they jump, how they land, how they move. We're looking beyond the knee, so their hip strength. We're looking at their alignment. Are they in valgus pronation at the ankle? Do they need orthotics? And so I think that kind of comprehensive thing can be very helpful in terms of trying to reduce that high risk of re-tear or high risk of re-dislocation.
Yeah. No, I think it's so important to look at these kids and see who's at risk. And it's amazing, actually, looking at somebody do something simple like a drop jump, that it can be so obvious who the kid is at risk. Yeah. But there's great studies that show that you almost don't even need to screen. You should just train everybody, right? Like the warm-up protocols that these teams are doing of just run a lap around the field and stand in static stretch have been shown to have crazy high rates of injury. And that if everyone does the more active dynamic warm-up, it can reduce that risk. I think that would go a long way to help reduce these injuries.
Yeah. Go ahead.
No. You sure? Because I had a question. You were at the table last night. We were talking to Anil Ranawat actually about this, and he brought up a really interesting question that I actually want to get your guys' thoughts on. So, you have a young female patient, let's say it's a family member, right? And they are in valgus and they are dying to play soccer. What is the indication? You had mentioned if you're going to do guided growth on one side, you'll do it on the other side just so that they line up. So one leg isn't straight and the other one isn't bowed. And even if the other side doesn't have any issues, that's asymptomatic surgery, right? Preventative-wise. What are your indications? Would you ever do a surgery at guided growth to lessen the development of genu valgum and perhaps lower the risk of a ACL injury in a young female athlete? I don't know who wants to take that one first.
It's a provocative question, I think.
That's why I asked it.
But I think in reality, it's very rare to do any sort of preventative surgery because, there are risks and costs associated with surgery. So, if you did a guided growth procedure and they overcorrected or they got infection or they got, stiffness or some issue afterwards, that would be a problem. I think in most of surgery, preventative surgery is, except in certain cases of like cancer surgery where there are very high genetic markers and a very high incidence of getting that cancer and that cancer can kill you, that preventative surgery might make sense in that situation. But genu valgum is not quite, severe cancer. So I would actually focus in that patient more on the biomechanics, right? So that's the ideal person that you want to be getting into, therapy or prevention center and working on correcting that dynamic valgus when they land. You work on strengthening the hip abductors, core stability, et cetera.
Yeah, I think that's the key word, dynamic, right? You can have a patient whose alignment is genu valgum, but when they land from a layup, for example, like their glutes are strong, their core is strong, and they don't land with that dynamic valgus and the increased force. You can also have the kind of, skinny, poor core control, poor glute strength athlete who has neutral alignment but lands with crazy dynamic valgus. And I think that's the patient who's at risk. Just having kind of, neutral, at baseline valgus, maybe, I don't know if there's any data that shows it's a risk, but I think it's that dynamic valgus of how they're landing mostly in these unanticipated situations. So getting them used to that being their set point, their standard of how they land when they are anticipating it, so that their body's natural inclination is to land that way when it's unanticipated is the key.
Yeah. No, I think those are great points. And
very good.
The last thing I wanted to sort of touch on was actually the psychological aspects at the end, because that's also, there's a lot of great data that shows if there's fear of re-injury and that kinesiophobia, that, maybe they're getting back to sport. Are they getting back to the same level, or are they changing the way they move because they're so cautious? And I know we see that a lot in the mountains, that, they don't attack the mountain the same way because now we're really scared, and that's going to change the way we move. So a brief sort of shout out to you. And so when, over 20 years ago, when I was a physical therapist for Carl Gustafsson, I was taking care of one of your patients. You'll never remember this, but I was taking care of one of your high school ACLs in Wellesley. And I very distinctly remember she was towards the end of rehab and physically doing really well, but crying all the time, and just had a lot of fear. And, also, to your credit, not a surprise. I would call your office, and either you or someone on your team would call me back because I'd say, I don't know what to do about this. This is sort of a little bit out of my league, and it sort of sparked. I think for me, even 20 years ago, oh gosh, this is really important. So one, thank you for not, as we all know, not every surgeon responds to a physical therapist, and you did, so thank you. But are you addressing that at all? Are you bringing it up? Are you giving them any awareness that this is sort of a risk factor as well?
It's definitely a topic I love talking about. I mean, I take care of a lot of female adolescent patients, and around the time that I'm giving them that advanced knee protocol where I'm saying, if you've got 70% strength, you can start running, and we've got 90% strength, you can start your agilities. I always have the conversation that physical readiness is very different than psychological readiness. And that psychological readiness, we know, lags behind a lot behind the physical readiness. And it does not mean you're a wimp, and it doesn't mean you're a bad soccer player. And it will come. And when it comes for you, then that's the right time to go back. And it's going to be different for everyone. But you need both elements to be cleared.
Yeah.
Yeah, it's a big part of it. I think the physical recovery and the mental recovery, and you won't know it unless you start talking about it, and you don't know it, and you don't want to talk about it unless you have the resources available. And so, like actually in our sports medicine division, we have 5 mental health specialists, sports psychologists, PhD sports psychologists, master's level psychology, who work with our patients. And so it's something we look at a lot. And, we've done a number of studies called ROAR, Readiness, ACL Return, using the ACL RSI index and other scores to look at their mental readiness to return back to sports and activities. And I think, we do focus a lot on their strength and their balance and their hop tests, but I think looking at their mental readiness to return is really important. And on the beginning end of the injury, I think also just bringing that up and it could be adolescent female, could be adolescent male. I think for an adolescent athlete who tears their ACL and now they're looking at a year recovery, and their identity is very tied to sports, their peer group's very tied to sports, their family unit is very tied to sports. It's a pretty devastating injury. And so just getting that out in the open, saying, look, we know this is a really bad injury and it's normal to feel sad, but if you're feeling really sad and like you don't know who to talk to and it's really getting you down, let us know. We've got some sports psychologists, and that's been very helpful on the coping end of it, at the injury side as well.
Yeah, that's great. Yeah. It's a nice resource.
Definitely.
Yeah.
Awesome. Well, thank you guys so much for taking time out of
That's
your very
awesome.
busy schedule to be here. This was very, eye-opening and very informative for our listeners.
Yeah.
So thank you so much.
It
we
was
really
fun. Thanks for
appreciate
having
it.
us. We appreciate it. Great job.
Thank you very much. What
Super
a great
honored.
conversation.
Yeah, thank
Great.
you.
Thank you for listening to this episode of the Sports Talks podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportstalkpod@gmail.com or find us on Instagram at thesportstalkspod. We love your feedback.